Hello everyone, this is video number 2 for the lower respiratory system. The first category we're going to talk about is pulmonary circulatory disorders. The first one there is your pulmonary hypertension. This is resistance of blood flow in the pulmonary circulation, which means there's a continuous high pressure in the pulmonary arteries, which increases the workload of the right ventricle. Some assessment findings, dyspnea. At first it'll be just on exertion, and later it'll be even at rest. They'll have weakness, chest pain, fatigue. They could have a JVD, orthopnea, and peripheral edema. Some management, we can give vasodilators, anticoagulants, and we want to manage the underlying disease if there's a cardiac or respiratory disease that is causing this continuous high pressure. Nursing management, we want to recognize signs and symptoms of respiratory distress. We want to prevent fatigue. We can do this by assisting with ADLs, making sure they're on bed rest if needed. We also want to administer oxygen if ordered. We need to remember that oxygen is a physician order. Another pulmonary circulatory disorder is a pulmonary embolism, which we have covered some with peri-op. It is the obstruction of the pulmonary arteries or branches, usually by a blood clot, usually from a DVT. This is an obstruction in the arteries which causes gas exchange impairment. So our assessment findings, it's an immediate onset of pain, tachycardia, and dyspnea. Medical management, we can give IV heparin or IV thrombolytic drugs, which it could be TPA. Surgical management, embolectomy, nursing management. The biggest thing that we need to focus on, the biggest thing is preventing a DVT. If we can prevent those DVTs, we won't have to worry about the possibility of a pulmonary embolism. Here's just a picture of what a pulmonary embolism could look like. I want y'all to know box 21.8. This talks about how to prevent pulmonary embolisms. Respiratory failure, this is the inability to exchange sufficient amount of O2 and CO2 for the body's needs. This is even at rest. Some causes could be COPD, neuromuscular diseases. If you look at table 21.5 on page 348, this gives you more causes of respiratory failure. Assessment findings, we could have apprehension, restlessness. So think of how are you going to feel if you don't have that O2 in your body. Medical management, we're going to maintain the airway. We can humidify oxygen, and we could possibly use mechanical ventilation. The biggest thing with respiratory failure is we want to treat the cause. There's usually an underlying cause as to why the respiratory system is failing. Nursing management, we're going to obtain emergency resuscitative equipment. We want to and notify the physician immediately if there's any changes. Assess respirations and monitor your vital signs. Here is an image that could be used to help determine the causes of respiratory failure. Next, we're going to talk about acute respiratory distress syndrome. This is an acute lung injury. It is a clinical condition that occurs following another clinical condition. The mortality rate is very high. Causes could be aspiration, vomiting, drug overdoses, smoke inhalation. Our assessment findings are going to have an increased respiratory rate, shallow labored respirations, cyanosis. They will be using accessory muscles. They will appear anxious and be confused. Medical management, we're going to give them O2. Again, remember that is a physician's orders. Mechanical ventilation or artificial airway. And yet again, we want to treat the cause, because remember this is a clinical condition. So we want to treat the cause. What is causing them to have an acute respiratory distress? Nursing management, we're going to assess and monitor the respiratory status. We're going to provide oxygen help with ventilation, anything we can do to help the respiratory system. Here is an image you can utilize for respiratory distress syndrome. Now we're going to switch to malignant disorders, which is your cancer. We're going to talk about lung cancer. Usually it is caused by prolonged exposure to carcinogens, which is normally your cigarette smoking. We need to make sure that this is also related to those exposed to secondhand smoke. Lung cancer is the leading cause of cancer deaths in the United States. Assessment findings, it's usually a cough that produces mucopurulent or blood-streaked sputum. This is usually the cardinal sign of lung cancer. They will start coughing up blood. They can also have anorexia, weight loss, dyspnea, and chest pain. Diagnostic findings, there you can look at chest x-rays, CT scans, PET scans, MRI, or a bronchoscopy. Medical management, we are talking about in cellular chemotherapy and radiation. There are different surgical managements that can be done, but the nursing management is we're going to provide emotional support and make sure we're taking care of them post-operatively. Prognosis is poor unless it's found early. However, it's rarely found early because there are very few symptoms associated with lung cancer until it gets into the later stages. Here is some different terminology for different parts of the lung that can be removed. Here is an image on how a normal lung looks different from a lung that has cancer. Very big difference. Now we're going to switch to trauma. First, we're going to talk about fractured ribs. Fractured rib is caused by a hard blow to the chest or a hard fall. It can usually lead to a flailed chest. A flailed chest occurs when two or more adjacent ribs fracture in multiple places and fragments are free floating. With a flailed chest, on inspiration, the segments move inward, which means there is a decreased lung space to expand. On expiration, the segments move outward, which decreases the ability for the lungs to push out CO2. So if you remember, this is the complete opposite of what the body does with normal respirations. Some assessment findings would be severe pain on inspiration and expiration. Respiratory acidosis, again, that goes back to your flailed chest because on expiration you have less movement for the lungs to push out that CO2, which means that CO2 is staying in the body, causing that respiratory acidosis. Medical management is they can use elastic bandages or a rib belt. However, it's not commonly used unless it's very much needed, just for the fact that you have a decreased lung expansion, which means there are at increased risk for respiratory complications such as pneumonia. We also have penetrating wounds. Penetrating wounds are common gunshot wounds, stab wounds. Assessment findings would be a pneumothorax, which is when air enters the thoracic cavity. A hemothorax is when blood enters the thoracic cavity. Subcutaneous emphysema, which is air in the subcutaneous tissue. Hemorrhage, lung contusion, damage to the surrounding tissue, and possibly even cause fractured ribs. Management would be airway management and emergency treatment. Some emergency treatments could be your thoracentesis. Another emergency treatment would be to make sure we never remove the object. We want to apply a secure dressing around the object to prevent air from entering in. I will post the PowerPoint, and this is a video that you can watch to see the flailed chest. Let's go back a little bit and talk about a little more in depth of that pneumothorax we talked about. So the pneumothorax, as I said, is when air enters the thoracic cavity. So what are some signs and symptoms that we could see? This could be shallow, rapid respirations, asymmetrical chest expansion, dyspnea, chest pain, absent breath sounds over the affected area, and bleeding. Tension pneumothorax is just a different type of pneumothorax in which there's tension inside the body system. So as the pressure increases, the unaffected side gets compressed. So the signs and symptoms would be a tracheal deviation. That's a huge, if you see tracheal deviation, you know there's a big problem. They can have bradycardia, cyanosis, and shock and death if not treated, because what's going to happen is on that unaffected side, it could put so much pressure on the heart, any organs that are on the unaffected side. All right, we're going to talk a little bit about some different surgeries. A thorectomy is any surgical opening of the chest wall. So reasons we would need this would be a removal of fluid, blood, air, tumors. We need a lung removal, repairs, a repair of any kind of trauma, and also a biopsy. Preoperative, we're going to get that lung assessment, get their history, look at anything we need to know prior to going into surgery. Post-operatively, we're going to have to maintain their chest tube. So over here on the side, you will see a chest tube. A chest tube, if there's ever a break in the chest tube system, it allows air to enter the tubing, which enters the pleural space. A chest tube has 3 different chambers. You have a drainage collection chamber, a water seal chamber, and a suction chamber. The drainage collection chamber can have bloody drainage, but it is not normal for it to be bright red or copious large amounts. In the water seal chamber, a fluctuation in the fluid is normal until the lungs re-expand. However, we need to make sure that there are no clogs, no suction malfunctions, or kinks, because that can also cause a decrease or no fluctuation. So we need to make sure there's no fluctuation for the right reason. And secondly, we have a suction chamber. Going back to the water seal chamber, there does not need to be excessive bubbling. If there is an excessive bubbling, we need to check for leaks. And if you do not notice any leaks, you need to notify the physician immediately. If you look for the client family teaching, it is 21.5 on page 359. It talks about teaching about surgery.